All right, good morning, students. Good morning, everyone. This is Dr. Kunaal Agarwal, your original guru for the subject of Orthodontics at DBMCI MDS. So, I welcome the new batch for the live classes. So, just a bit introduction about myself. I've done my BDS from Maulana Azad Institute of Dental Sciences, New Delhi, and MDS in Orthodontics from GDC Bangalore in the year 2016. I completed my post graduation in the year 2016, and since then I've been associated with a college in my hometown, that is Bhopal, Madhya Pradesh. Right now I'm working as an associate professor, due to be promoted as a professor by the end of this year. So also I'm practicing at my own clinic since last more than 8 years now. So by God's grace, I have a kid, I have a family, and so with that note, let's start. I hope you're having a good time studying. You're taking good care of yourself. Everyone is good taking good care of yourself, and I believe you all are preparing for the exam, which is scheduled next year. Maybe some of you might be giving exam this year as well, but I believe maximum of you are preparing for the exam scheduled for the next session, that is 2016. Sorry, 2026. One second. Yeah. Right. So I'll be talking about different topics in orthodontics, and I'll be stressing more upon the topics which are more important from this point of view of exams, which are questions which are framed from such topics, which are important from the point of view of NEET and INI-CET exam. As we go along the course, I'll be highlighting those points. I'll be making a point for you that you have to note it down somewhere, that which point is important, some factual value is important, some theoretical value, some theoretical concepts, some implied concepts, some clinical concepts. So I'll be discussing about them as we go forward in the course of the orthodontics today, right? And just to make myself very clear, since the very beginning, I have referred all standard textbooks to prepare my content. I have referred to Graeber Vanarsal textbook. I have referred to Prophet. I have referred to Gurkirat Singh, Balaji, then some certain other textbooks pertaining to different topics in particular, specifically Cephalometrics by Jacobson, then Dr. O.P. Kharbanda, then Donald N. Lowe. So all those books I have referred. So Sridhar Prem Kumar, I've taken many images from that textbook called Sridhar Prem Kumar. So I believe the content, which whatever I'm talking about, or whatever I'm going to talk about in the due course of time, should not be controversial. I have given my best to prepare the content error free, but since we all are humans, some error is inevitable. Maybe some spelling mistake here and there, maybe some spelling mistakes in the notes, but that doesn't mean the notes are not important. Notes are very important. And when I say that all the faculty have put in their maximum effort to create content for you, we all of us at DBMCI, all the faculties unanimously at DBMCI expect some gratitude, some regard, even if something goes wrong, even if you're not able to understand the concept, just stop me or stop anyone else in the due course of lectures in different subjects also. So the USP of DBMCI is hand holding of the students basically. So we'll give our best to hold the hands, so to guide you properly and see you through the finish line. Okay, so with that note, let's start with the chapter growth and development of cranial and facial structures. I'll be discussing about the general concepts of growth and development in the next lecture from now. Right? So starting with the cranial vault. What is a cranial vault? Shilpa has asked me to please discuss the time of fusion of fontanelles also. Yes, I will discuss. Just wait a bit. I'm coming to that one by one. So cranium is divided into two parts: the cranial vault, this is the vault, and the cranial base, that is the base where the brain lies. Okay. So talking about the cranial vault. So as the child is born, you can see the face of the child is very small. whereas the size of the cranium, the cranial vault is quite large, right? But since the child has to pass through the birth canal at the time of birth by the mother, so the flat bones of the cranial vault, they have to be little moldable, they have to be malleable to enable to facilitate easy and uneventful passage to the birth canal. For that, the nature has given something called as fontanelles. So these are fontanelles. So these are nothing but loose connective tissue present between the junctions of the flat membranous bones present in the cranial vault. Okay, so you can see there are different fontanelles. We have anterior fontanelle, we have posterior fontanelle, we have mastoid fontanelle, and we have sphenoid fontanelle. There are total 6 fontanelles. Sphenoid and mastoid fontanelles are present in pair, right and left side, and anterior and posterior fontanelles are present as a single unit along the mid-sagittal suture of the cranial vault. Okay, so this is the sagittal view, and this is the top view of the cranium. So, Shilpa, this is the answer. So, please discuss the time of fusion of fontanelles. So, as the child is born, as the bone matures with time, the fontanelles also, the connective tissue of the fontanelles also get converted into properly ossified bones. When does that happen? The anterior fontanelle, this one, the fusion after birth is around 36th month. This table is important. You might get certain MCQs out of this particular table, so please make a note of it. Then posterior fontanelles, they fuse around 8 to 12 weeks, that is third month of life after birth. Then sphenoidal fontanelle, they fuse around 6 months, and mastoid fontanelle, the timing of fusion is quite variable. It varies from 6 months to 18 months after birth in few individuals. So I hope that answers your question, Shilpa. Let's move forward. Coming to the growth of the cranial base. Now, as I said, cranial base houses the brain. The entire weight of the brain is supported by the cranial base. So in the next few slides, I'll be discussing the growth pattern of the cranial base and the growth pattern of the entire facial skeleton as well. Okay. So in this figure, you can see the remodeling in the cranial vault. Cranial vault and cranial base, I said, cranial base is supporting the weight of the brain, but cranial vault is remodeling according to how the brain expands, how the soft tissue expands. So there's a particular theory called functional matrix theory. I hope everyone is aware of that. Everyone must have read that in their final years. So I'll be discussing about different theories in the next session from now. So according to functional matrix theory, the growth of the bones, the growth of the hard tissues of the body is always secondary and compensatory to the growth of the soft tissues. That is the fundamental crux of the functional matrix theory. Okay, so the brain is a soft tissue. Brain is a soft tissue. It expands in volume. It expands in the content of the brain, of the gray matter and the white matter both. So because the brain is expanding volumetrically, to accommodate that growing brain in the cranial vault, the cranial vault also grows. The bones of the cranial vault also shift apart, and that also grows at the sutures. Sutures between the parietal bone, between the occipital bone, between the temporal bone, and different kinds of sutures, frontal bone. But in the cranial base, what is happening? Since I said the cranial base is the weight of the brain is there on the cranial base. So first of all, cranial base is made up of different bones, that is occipital bone, sphenoidal bone, ethmoidal bone, and some part of frontal bone as well. So the joints between these bones at the cranial base, they are made up of primary cartilage. There are 2 types of cartilage, I hope you are aware: primary cartilage and secondary cartilage. Now, secondary cartilage is always adaptive in nature. The growth of secondary cartilage is always adaptive in nature. I'll be discussing about that in the next chapter, next lecture from now. Whereas the growth of the primary cartilage is always and always genetically determined. That is the fundamental difference between the 2 types of cartilage. That said, primary cartilage growth does not depend upon the external environmental influences. That means It doesn't depend upon the nutritional status of the child. It doesn't depend upon the infections which the child endures during the growth of the child. So the growth potential of the primary cartilage is always genetically programmed. So, s- so these primary cartilages present along the different bones along the base of the skull are known as synchondroses. Are known as synchondroses. So these are primary cartilage, right? So you can see this is a part of sphenoid bone, and this is a part of occipital bone, basi-occiput. So the junction between the two bones is filled up by this blue colored band of tissue, which is known as synchondrosis, that is primary cartilage, right? So as I said, the base of the skull houses the brain, the weight of the brain. So we have pressure or compression adapted growth at the sutures. Please remember this word, this term. We have pressure or compression adapted growth at the sutures, whereas whereas in the cranial vault we have tension adapted growth at the sutures, right? That is the difference between the two. Now this is one more diagram of the same of the synchondrosis. We have basi-occiput, we have sella turcica, which is a part of the body of the sphenoid. We have ethmoid bone. One second. Then we have different types of synchondrosis. We have spheno-occipital synchondrosis, spheno-occipital synchondrosis, spheno-ethmoid synchondrosis, intersphenoidal synchondrosis, and one more intra-occipital synchondrosis. So on the right, you have different times of fusion of the synchondrosis. Again, an important table. The spheno-occipital synchondrosis fuses by the age of 18 to 20 years. Spheno-ethmoidal by 2 to 25 years, such a variable timing in the time of fusion. Then intersphenoidal at birth, and intra-occipital synchondrosis fuses by 3 to 5 years after birth. Now, out of the four synchondroses, the spheno-occipital synchondrosis is the most important, and this synchondrosis is also known as pacemaker of growth of cranial base. There's one more pacemaker of the facial skeleton, of the maxilla especially. We'll discuss that in the coming slides. For now, we have to remember the pacemaker of growth of cranial base is the most important synchondrosis, that is spheno-occipital. Okay, so please remember that. So Khushi has asked me to please call up that the table is not given in notes. But it is given in notes. This table is given in notes. I have myself prepared that these slides, and the table has been given in the notes. Okay. Nandana has asked me to please show the last slide. Which slide do you want me to show, Nandana? Please let me know. Now, coming to the facial skeleton, till now we have discussed about the growth of the cranial vault and the cranial base. One more thing, the growth of the cranial base, the direction of growth vector of the cranial base is always upward and forwards. Upward and forward. Please remember this. The direction of growth vector of cranial base is upward and forward. Okay? Whereas the growth vector of the nasomaxillary complex is forwards and downwards. Now, why does this happen? I'll explain that also in a bit. Now, the overall growth vector of nasomaxillary complex is downward and forward, as I said. Now, what happens? The facial skeleton is made up of different bones, where the maxilla takes up the maximum type maximum part of the facial skeleton. You all know that there are two maxillae, right and left side, which are joined at the center. Since maxilla is present in the facial skeleton at such a junction, at such a juncture that there are different surrounding bones articulating with the maxilla with different sutures, right? So as I said earlier, growth at the sutures is always tension oriented, whereas growth at the base of the skull is always compression oriented, compression adapted. So now why the growth of the maxilla is downward and forward? That's because the growth at the cranial base is upward and forward. The direction of growth of the thin chondrosis is upward and forward, correct? Now because of that, what happens? One second, what happened? Now because of that, what happens? The maxilla and the rest of the cranial facial bones are attached to the base of the skull. So if something is going forward at an angle, we have two components. If you divide that vector into two components, we have a vertical component, we have a horizontal component, right? Similarly here also we have a x component and we have a y component. Also there is one more component, that is z component, but since this is a two-dimensional figure, I cannot show the z component here. So the cranium is moving in a forward direction. So because of the x component, that is a horizontal component, the maxilla also gets shifted. It also gets pushed forward. The maxilla also gets pushed forward. Now because the anatomy of the maxilla is such that it is articulating with the base of the skull at an angle. So this is the base of the skull. Because the base of the skull is going upward and forward, the maxilla is simultaneously pushed downwards and forwards. So downwards and forwards. So this is an important MCQ. This is an important concept rather, because you will be asked certain questions, maybe in a twisted manner. The language of the question might be a little twisted. So you are supposed to grasp this concept by heart and then visualize that what the question is asking in the language of the question. Maybe you have to read the question 2 times, 3 times, even sometimes 4 times. Then form an answer in your mind before jumping to reading the options available. Form an answer, then read the answers, then read the options and tick mark the most appropriate one. That is the correct way of answering an MCQ. Okay? So this diagram shows the predominant growth vector of different sutures, but this diagram is not very important. What I mean to say, that the collective growth of the facial skeleton is always downwards and forwards, whereas of the base of the skull is upwards and forwards. So I hope this is clear. So this diagram again shows the cutout section of the base of the skull. This is the frontal bone, this is the sphenoid bone, this is the occipital bone. We have different sutures available, and at the center in the midline, this blue colored bar is called the synchondrosis. I told you spheno-occipital synchondrosis is the most important one out of the different synchondrosis present, which is the pacemaker of the growth of the cranial base. Okay. Now coming to the growth of the nasomaxillary complex. Although I've already explained that to you in the previous slides, but still we'll be discussing about that in much detail in this particular slide. So what happens? I hope you are aware about the Scammonn's growth curve also. That also I'll be taking in the next lecture from now. So Scammonn's growth curve says that the neural tissues completes its growth by approximately 90% by the time the child is 5 to 6 years of age. I hope you remember that. Everybody must have read that in their final year exams. So because the brain is growing at a very rapid rate, the cranial vault increases in size so much that cranial vault, the growth rate of the cranial vault, it exceeds the growth of the nasomaxillary complex. That's why it is said the cranium, the brain grows in size first, followed by growth of the face. That is explained by the Scammons growth curve. Now, in order to maintain that pace, rather in order to for the maxilla to catch up that growth of the cranial vault, there is tension adapted growth at the sutures. So by the time the child is 0 to 5 years, there's 85% of total growth is completed. By the time the child is 5 to 10 years, 96% of growth is completed. And by the time the child reaches 20 years, the remaining 4% growth of the cranial vault is completed, and of the nasomaxillary complex is also completed. So that's why it is said that initial 5 to 6 years of a child's life are very important from the point of view of development of the neural structures, especially the brain, especially the intelligence center, especially the speech center, hearing center, and most importantly, the emotional center of the brain. The limbic system of the brain is very important. It is very sensitive. Children are very sensitive. They want instant gratification. You know, I hope everybody must have had children in their houses, maybe cousins, children, some uncle, aunties, children. So everybody must be knowing how fragile children are at this stage. So it is imperative for the parents to give proper, adequate emotional support. They have to be available for the child. So that's what I mean to say, that you should not depend upon maids to take care of the child, caretakers, nannies. Especially the mother has to be emotionally available to the child during initial 5 to 6 years of life, for the child to develop a proper emotional bonding with the mother and the parents. Okay, right? Now, talking about the maxilla is an intramembranous bone. First of all, maximum part of the maxilla is made up of mesenchymal condensation converting into intramembranous ossification of the condensed mesenchyme. So this diagram shows a serratus section through the zygomatic arch. Now we have deposition of bone at the posterior surface and deposition of bone at the maxillary tuberosity in the vertical aspect, in the vertical plane of space. That's how the maxilla grows. And this is the axial section of the maxilla. This again shows how the maxilla grows, the hamular process of the maxilla and the tuberosity of the maxilla. Maximum growth is occurring at these 2 points. Maximum bone remodeling is occurring at these 2 points. Now, because of Newton's third law of motion, every action has equal and opposite reaction. You all know that. What is that? So if suppose something is pushing against the more robust bone, maxilla is attached to the sphenoid bone, right? But sphenoid bone cannot move because it is present at the center of the cranium, at the center of the skull. It's a landlocked bone, you can say. So if something is pushing against that bone, the maxilla is growing at the posterior surface. So because bone is getting deposited at the posterior surface, the entire maxilla gets shifted anteriorly. The entire maxilla gets shifted anteriorly. This is an example of primary displacement. Now, what is primary displacement? Primary displacement is the growth of the bone. Listen to me very carefully. Primary displacement is the growth of the bone by virtue of its own growth. Or you can say it in a manner, primary displacement is the remodeling of the bone by virtue of its own growth. Here, I have taken example of maxilla is growing at the posterior surface. Since the posterior surface is enduring bone deposition, the entire maxilla gets shifted anteriorly and downwards. I told you the reason before. So we have primary displacement of the maxilla, plus we have secondary displacement of the maxilla as well. Now, what is secondary displacement? I told you earlier, the growth of the cranial base is upward and forwards. Based on that, the growth of the maxilla and the entire nasomaxillary complex is downwards and forwards. I told you the reason. We divide the two components into X and Y components, and because of the X component, the maxilla also gets pushed anteriorly. Now, when the bone shifts its position in space due to push from the surrounding structures, due to push from the surrounding bones. That is, in this particular case, the maxilla is getting shifted due to the growth at the base of the skull. That means the base of the skull is pushing the maxilla forward. The maxilla is getting pushed forward not only because of its own growth, it is getting pushed forward because of the growth of the cranial base also. So this is known as secondary displacement. Is it clear? Please let me know in the chat box on YouTube. Is it clear? Or do you want me to explain this again? Please let me know. I'm waiting. Tanishka has asked me to explain this point again. Primary and secondary displacement. All right. So primary displacement, I said, it's a movement of the bone by virtue of its own growth. That is primary displacement. Whereas secondary displacement is the movement of the bone in the spatial plane by growth of the surrounding bones. In this particular case, the cranial vault is growing in an upward and forward direction. That cranial vault is pushing the nasomaxillary complex in a downward and anterior direction. So we have secondary displacement of the maxilla. So now you have an MCQ, rather not an MCQ, rather it's a concept. It's a concept. So maxilla undergoes both primary and secondary displacement. So maxilla, by virtue of its own growth, it undergoes primary displacement, plus the maxilla by virtue of the surrounding bones, especially the cranial base, it gets pushed anteriorly and downward, leading to secondary displacement. So maxilla is a combination of primary and secondary displacement both. That is the core concept what I want to emphasize on. Right? Niharika has asked me to please explain bone deposition and tuberosity. But is nothing. Tuberosity, bone deposition, occurs in a vertical direction and at the hamular process of the maxilla, where the maxilla connects, where the maxilla articulates with the pterygoid plates of the sphenoid bone. That part of the maxilla also undergoes bone deposition in a posterior direction. That's all. Okay. Now, another concept is known as surface remodeling. Now we have one more concept called surface remodeling, which is quite confusing sometimes for some students. So again, I want you to pay attention here. Now, as I said, maxilla is undergoing movement by two methods, primary and secondary displacement. Now just imagine if you're pushing something. If I'm pushing my mobile forward, do I have any control over it? Or there are chances that the mobile might get toppled over? Yes? That is just an arbitrary example I've taken. Now, to control the excessive growth of the maxilla, rather to keep the growth of the maxilla in check, what nature has given? Nature has given something called as surface remodeling. Right? एक minute. What Niharika has asked me, why are arrow pointing in different direction in the diagram, sir? Which arrows, bache? So this is upward and forward. This is downward and forward. That's why they are pointing in two different directions. Which arrow are you talking about? These. Okay. I told you, na? This is the posterior surface of the maxilla. And this is the tuberosity of the maxilla. So it just shows the arrows show the areas where surface deposition of the bone is taking place. That's all. That's why the arrows are in different directions. Now I was talking about surface remodeling. Now to keep the growth of the maxilla in check, nature has come up with something called as surface remodeling. What happens if the maxilla gets pushed by two mechanisms, primary and secondary displacement? There are chances that the maxilla will overgrow. The maxilla might convert into a snout. we might have a beak-like appearance of the face. To avoid that, surface remodeling comes into picture. Now you know the posterior surface of the maxilla is undergoing bone deposition, right? The maxilla is getting pushed anteriorly and downwards by secondary displacement. To control that, the anterior surface of the maxilla, the part which is shown in yellow color here, the shaded part, the anterior surface of the maxilla, it undergoes bone resorption. It undergoes bone resorption. So that comes under surface remodeling. If something is going forward, we have to put a break. We have to keep it in check. That check is given by surface remodeling, which is shown in this diagram by surface resorption of the bone along the anterior surface of the maxilla. That is what surface remodeling is. I'll explain that in this diagram also. The same concept, surface remodeling. Now imagine in this diagram, there are three workers. One worker is pulling the cart in this direction. This is number one worker. This is number two, and this is number three. Now, first worker is pulling the cart in a left side direction. This is going towards the left. Now, imagine the first worker. I'll just put it as an analogy. So, first worker is the synchondrosis. I told you synchondrosis is the primary pacemaker of growth of the cranial base. That's the primary cartilage. So the first worker is pulling. That is the first worker is keeping a pace to the speed of movement of the cart. This is the platform. That is the cart I'm talking about. Now because of that, the maxilla is getting pushed anteriorly and downwards. You know that. Now the posterior surface of the maxilla. The posterior surface of the maxilla is undergoing bone deposition, where the third worker is putting bricks along the wall on the posterior surface. Whereas the anterior surface of the maxilla, that is worker number 2, is removing the part of the bricks. So we have a combination of cortical drift, primary displacement, secondary displacement, and surface remodeling in this particular diagram. You can see in the legend of the diagram, the surface remodeling of a bone is in the opposite direction to that in which it is being translated by growth of the adjacent structures, creates a situation analogous to the cartoon, in which the wall is being built to move it backwards. At the same time, the platform on which it is mounted is being moved forward. So this is the core concept. This is what I am trying to explain. The concepts of surface remodeling, cortical drift, primary displacement, and secondary displacement. Right? So this is the maxilla. This is the anterior surface of the maxilla. This is the posterior surface of the maxilla. And this is the cranial base. The cart is analogous to the cranial base, which is the primary pacemaker to keep it in check. The anterior surface of the maxilla excuse me, the anterior surface of the maxilla is undergoing surface remodeling by selective resorption of the bone, and posterior surface of the maxilla, that means at the tuberosity and hamular part of the maxillary region, it is undergoing selective bone deposition. Okay. Excuse me. Now this figure also shows with time how the anterior surface of the anterior cranial fossa grows. You can see the anterior cranial fossa grows. This is a time dependent diagram, has been taken from textbook of Orthodontics by William R. Prof. To keep pace with the anterior fossa, the maxilla has also grown in the particular pace. So this mechanism I explain in the next lecture, that is called counterbalance. That is called balanced growth phenomena, basically. So Niharika has asked me in which is higher in case of maxilla, resorption or deposition. We cannot say which is higher or which is less. Both of them go hand in hand. Okay? Both of them go hand in hand. So the overall result of the maxilla is slightly forward direction. Excuse me. So Pino has asked me in surface remodeling, so there is time after that surface remodeling stop. But a surface remodeling is a lifelong process actually. You know, the structure of the bone, it forms, it deforms, it always keeps on changing depending on the circumstances. So surface remodeling is always and always, it's a universal phenomena. It's always that this process is very intricately regulated. Some part of the bone is going undergoing resorption, some part of the bone is undergoing deposition. So in order to maintain the width, quality, and the functionality of the bone as and when required. So you cannot say which is more, which is less. Okay. Now the second figure also shows the same thing, that to keep pace with the growth of the maxilla, the mandible is also growing in a forward direction. Same pattern has to be followed, downwards and forward, similar to that of the maxilla. Similarly, the vault of the maxilla is also growing in this manner by following V principle of growth. I'll explain these principles in the next lecture. V principle of growth given by Enlow. Okay. So Deep Priya Ambassa has asked me to please explain cortical drift. But a cortical drift is nothing but it's a movement of the bone. What I was talking about, no, just a while ago. The entire bone moves in a particular direction depending on many other factors, depending upon primary displacement, depending upon secondary displacement. So that movement of the bone is called cortical drift. Now Niharika has asked me, what about primary and secondary displacement? Do they occur lifelong? Well, no. Primary and secondary displacement do not occur lifelong. It stops when the growth of the skeleton is completed. That means around 18 to 20 years of age, right? Now this figure also shows the same thing. Now this is a better figure than the previous one. You can see the maxilla undergoing excessive bone deposition along the posterior surface, along the hamular process, and along the maxillary tuberosity. The alveolar process of the maxilla also grows forward, also grows vertically downwards, not forward, because of the eruption of the teeth. Then the zygomatic process of the maxilla also grows in the directions of the arrow as given, and the nasal bone, the part just below the nasal bone, along the piriform aperture, also undergoes bone deposition, but primarily the anterior surface of the maxilla undergoes bone resorption. So that's what you have to remember because of surface remodeling. Okay. Now the next concept, that is rotation of jaws. This is an important concept. This is this is a little confusing concept. I hope I'll be able to explain you properly. So what happens? Rotation of jaws is a concept which is relative to each other, which is related to each jaw and to the external observer as well. Suppose I'm an observer, I'm studying a person, I'm studying a child undergoing growth. So what I'll explain, what I'll observe is that how the maxilla and how the mandible rotate in relation to each other, number one, and how do they rotate in relation to an external reference point. So we'll be studying the growth of rotations. We'll be studying the growth we have and the rotation of the jaws under two headings, that is relative to each other and relative to an external point of reference. Until longitudinal studies of growth using metallic implants in the jaws were carried out in 1960s, primarily by Jock and co-workers in Copenhagen, the extent to which both maxilla and mandible rotate during the growth was not appreciated. Now, many people have done certain experiments. As I said earlier, we'll be talking about those experiments in the next lecture. The reason that rotation that occurs in the core, which is called internal rotation, tends to be masked by surface changes or alteration in the rate of tooth eruption. Now, as I said, when we are looking at the jaws from an external point of reference, that rotation of the jaws is not very well appreciated because it is very subtle. It is very, very subtle. It's only and only once you do longitudinal studies of the jaws, only then you can appreciate the degree of rotation of the jaws. Otherwise, you cannot appreciate that because it is very, very difficult to see by naked eyes. Now, because the cranial base is growing, the cranial vault is growing, the nasomaxillary complex is growing, what we have studied so far. Based on that, so far we have discussed about the growth and development of the maxilla and the cranial base. What about the mandible now? What about the mandible? To keep pace and to keep relationship intact with the maxilla, the mandible undergoes some rotation. That is what is called as rotation of jaws. And that's exactly what we are going to study in this particular topic. Now, the reason is that the rotation that occurs in the core of each jaw, called the internal rotation, tends to be masked by surface changes and alteration in the rate of tooth eruption. As I just said, how the maxilla is growing, both by primary displacement, secondary displacement, but how that growth of the maxilla is negated by means of surface resorption, surface remodeling. Right? Now, that's what I said. We cannot appreciate the growth of the jaws per se because it is very subtle. Now, whatever rotation is occurring in the core of each jaw is called as internal rotation. You have to remember these certain terms: internal rotation and external rotation. And that internal rotation is negated by surface remodeling. So that surface changes produce something known as external rotation. Obviously, the overall change in the orientation of each jaw, as judged by the parietal plane and mandible plane, results from a combination of internal and external rotation. So the overall change in the orientation of each jaw is a combination of internal and external rotation. So you have to remember this. Then it is easier to visualize the internal and external rotation of the jaws by considering the mandible first. The core of the mandible, again, important point. The core of the mandible is the bone that surrounds the inferior alveolar nerve. The rest of the mandible consists of its several functional processes. That is the microskeletal processes. We have the condyle, we have the angular process, the alveolar process, the symphyseal process. Right? So these are the microskeletal units. The core of the mandible rotates during growth in a way that would tend to decrease the mandibular plane angle. Beta, Niharika, I am explaining that. The core of the mandible rotates during growth in a way that would tend to decrease the mandibular plane angle. That is up anteriorly and down posteriorly. This can occur by rotation around the condyle or rotation centered within the body of the mandible. Now, the core of the mandible, that is a part of the bone which surrounds the inferior alveolar nerve canal and the neurovascular bundle, it grows in such a way that would tend to decrease the mandibular plane angle. That means the mandibular plane angle is the angle formed by the base of the mandible when compared with the Frankfurt horizontal plane. We'll discuss about that in the chapter when we talk about cephalometrics. That is up anteriorly and down posteriorly. This can occur either by rotation around the condyle or rotation centered within the body of the mandible. Right? Excuse me. By convention, the rotation of either jaw is considered forward and given a negative sign if there is more growth posteriorly than anteriorly. This would bring the chin upward and forwards. The rotation is backward and given a positive direction if it lengthens anterior dimensions more than the posterior ones, bringing the chin downwards and backwards. That means if the chin is rotating, suppose this is the mandible, This is the chin. If the mandible is rotating, if the mandibular plane angle decreases, that means the mandible is rotating upwards and forwards. That means in an anti-clockwise direction. That is given a negative sign. But if the mandible rotates in such a way that it increases the mandibular plane angle, and the mandible rotates downwards and backwards in a clockwise direction, so that sign convention is given a positive sign. For an average individual with normal vertical facial proportions, however, there is a 15-degree internal rotation from age 4 to adult life. Out of this, about 25% results from rotation at the condyle and 75% results from rotation within the body of the mandible. Now, this line is important. It is a direct pickup line. You can be asked a factual MCQ based on this line. So, you can remember this. During the time that the curve of the mandible rotates forward an average of 15 degrees, the mandibular plane angle representing the orientation of the jaw to an outside observer decreases only 2 to 4 degrees on an average. So this value, only 2 to 4 degrees, holds importance. So you can say that the effective rotation of the jaws is only 2 to 4 degrees when observed from an outside observer, from an outside reference point. But at the same time, the actual degree of rotation is around 15 degrees. So 15 minus 4, that means 11 degrees. 15 minus 4 equal to 11 degree. That 11 degree difference in the rotation is masked by surface changes, surface remodeling changes. That's what it means. So this is the core of the mandible. That is the bone surrounding the inferior alveolar nerve vessels and the blood and the nerves. So rotation can have 2 points, two axis of rotation rather. Rotation around the condyle. So this is the condyle. So you can observe from the front that the transverse axis is going along both the condyles, and the mandible just undergoes a hinge rotation. Mandible just undergoes a hinge rotation upward or downward. So this is known as matrix rotation. So the hinge rotation of the mandible along an intercondylar axis is simply known as matrix rotation. Whereas rotation centered within the body of the mandible, that means in this case, the center of rotation is somewhere over here, around the third molar in the mandible. So when the mandible grows, when the mandible rotates with the center rotation along the third molar or along the last erupted molar, this is known as intramatrix rotation. Right? Actually, Jork has done a lot of research on rotation of the jaws. This was the person who is given credit for this. So Aarti has asked me to please explain the last point. But matrix and intramatrix rotation is simply, matrix rotation is when the rotation is occurring around the intercondylar axis in the transverse plane. Whereas intramatrix rotation is the one where the axis of rotation shifts from the condyle to the third molar or the last erupted molar. So the ramus of the mandible does not undergo any rotation. It's only the body of the mandible that undergoes rotation in either upward and forward and downward and backward direction, either a positive direction or in the negative direction. So that is called as intramatrix rotation. Is it clear, Aarti? Now this is a table given in Profit. So different authors have come up with different terminologies of the same concept, that is rotational changes of the jaws. So as I said, Jork has worked extensively and his work is considered the gold standard. So whatever terms he has given, we'll go by that only. because there are other terms given by different authors, Solo and Houston and Profit, which mean the one and the same thing, but they might be a little confusing. So, for the sake of simplicity, I'm skipping Solo and Houston and Profit's terminologies. I'll be sticking with Jog's terminology for the rest of the discussion. So, whenever posterior growth is greater than the anterior, we have forward rotation. As I said, the mandible is rotating upwards and forwards in an anti-clockwise direction. That is forward rotation by jog. Then whenever we have anterior growth greater than posterior growth, that means the anteriorly the jaw is rotating in a downward and backward direction in a clockwise direction. That is known as backward rotation according to jog. Then rotation of mandibular core relative to the cranial base is known as total rotation, whereas rotation of mandibular plane relative to cranial base is known as matrix rotation. I told you rotation of mandibular plane. In this diagram, we have matrix rotation, we have intramatrix rotation, and the rotation of mandibular plane relative to the core of the mandible is known as intramatrix rotation. I know this is a pain to remember, but if you understand the concept, if you understand the rotation concept, looking at these diagrams, you can take screenshots if you want to. So you will be in a better position to understand what exactly I'm wanting to say this. So this diagram was given by Jork. It's a landmark article published in American Journal of Orthodontics. I don't remember the year. The topic, the title of the paper was Prediction of Mandibular Growth Rotation. So these figures are taken from that particular article itself. So mandibular rotation, there are different types of mandibular rotation possible. Forward rotation with the center located at the joints. As I said, this is the transverse axis, intercondylar axis on both sides. So the mandible can rotate anteriorly forward or posteriorly downwards in a negative direction or in a positive direction, right? So that is known as forward rotation or backward rotation. The second is forward rotation with the center located at the incisors. That means here the center rotation is present at the incisors. That means the anterior part of the jaw is not growing at all. Only the maximum part of growth of the jaw is occurring in the vertical direction in the ramus of the mandible. So this patient, the B patient, will develop a deep bite, more of a horizontal growth pattern, right? Then C is forward rotation with center located at the premolars. We have third concept also, where the center of rotation is present along the premolars, here in the middle of the jaws. So we see some amount of posterior growth and some amount of anterior growth also. That is a third possibility. Then fourth possibility is backward rotation with center located at the joints. That means this is the intercondylar axis and the mandible is rotating in a downward and backward direction. So we have open bite tendency in figure D, and we have vertical growth pattern also in the figure D. And the fifth point, backward rotation with center located at the last occluding molar. So last occluding molar is mostly either the third molar or the second molar. So we have center rotation here, and we can see some amount of growth occurring in the vertical plane, vertical direction along the ramus, and some amount of growth occurring in the anterior region. That means the growth pattern of the mandible is maintained as such, and that is where it is called backward rotation with center located at the last occluding molar. So I hope this is clear. So concept behind matrix and intramatrix growth rotation. Matrix rotation, I told you, we have center of axis located at the condyle. That is the matrix rotation, right? The mandible can either grow in a negative direction, anti-clockwise, or in a positive direction, that is clockwise. Okay. Then Figure B and C show intramatrix rotation occur due to remodeling changes around the corpus of the mandible. Now, in actuality, I told you in actuality, for an external observer from an external point of reference, option, so not option, the figure B is what is actually observed. The rotation of the jaws is always and always a combination of matrix and intramatrix rotation. Matrix rotation means some part of the rotation is present at the axis at the condyle, whereas a significant part of the axis is present along the last erupting molars, last occluding molars. So we see some amount of growth here, a little bit of growth here also. Whereas in the third case, so we have forward intramatrix rotation. Forward intramatrix rotation means the anterior part of the mandible is hitting against the anterior part of the maxilla. So this will lead to deep bite. And backward intramaxillary rotation means the posterior part of the maxilla is growing more and the anterior part of the maxilla is growing less. So we have an open bite tendency in the C. Right? So I hope that is clear. Harshita has asked me to repeat the last point. Beta, which point do you want me to repeat? Dr. Pooja has asked me, can you please explain the difference between point and point in the previous slide? I got confused in that. Point A and point D. Okay. Excuse me. So point A, I mean figure A and figure D is the same thing. The only difference is the direction of growth of the mandible, basically. In A figure, the mandible is growing in an upward and forward direction, whereas in D figure, the mandible is growing in a downward and backward direction. So we have forward growth and we have backward growth. That is the only difference between point A and point D. Okay. Traveling vlog has asked me, what is V study? Beta, V principle of growth, that is called, not V study. As I said, I'll be taking that concept in the next lecture. So please make it a point to attend that lecture also. So I hope that is clear till now. We have talked about the growth of the cranial base, the maxilla, and the rotation of the jaws. Now we'll be talking about growth of the mandible also. Now in the prenatal age, the mandible always grows like in this diagram, what is shown in the figure. So Meckel's cartilage is the primary cartilage of the second branchial arch, I think, if I'm not wrong. So Meckel's cartilage forms a scaffold around which the mandible develops. The mandible as such, the mandible per se does not develop from the Meckel's cartilage. It degenerates with time. So we have got different remnants of the Meckel's cartilage, the leftovers of the Meckel's cartilage, but actually the mandible, more than 95% of the mandible is made up of intramembranous ossification. The intramembranous ossification of the mesenchymal condensation of the connective tissue. Only the condylar part, just a little bit of condyle and little bit of mental ossicles are formed by Meckel's cartilage. Otherwise, the entire mandible is made up of intramembranous ossification. So the initial site of osteogenesis is where the mental nerve, is where the inferior alveolar nerve divides into two branches, that is the mental nerve and the incisive branch at the future mental foramen. That is the point where initial site of osteogenesis occurs in the mandible. So I have presented an MCQ here. Right? The second figure shows how the Meckel's cartilage degenerates with time. So it forms separately. This blue colored diagram, it forms separately. So the part of the mandible which will form the future body of the mandible, this part is not joined with the Meckel's cartilage initially. Later on, it fuses with the mandible body at 4 months, and situation at the birth, where you can see the Meckel's cartilage is degenerated to form only a little bit of condylar cartilage. Rest the rest of the Meckel's cartilage is entirely gone by the time the child takes birth. Now, this figure shows an overall schematic representation how the surface remodeling changes occur in the mandible. So we have chin growing forward. So we have bone deposition. The inferior surface, the inferior mandibular plane also grows vertically downwards. So we have bone deposition here as well, significantly. The posterior surface of the ramus also undergoes significant bone deposition. Anterior surface of the ramus undergoes significant bone resorption in order to make space for the for not yet erupted first, second, and third molars rather. The alveolar part of the mandible, it also undergoes bone deposition in accordance with the eruption of the teeth. The alveolar process is formed after eruption of the teeth. And the condyle part undergoes subperiosteal bone formation, subperiosteal bone deposition in a superior and backward direction. Now, subperiosteal bone formation is also one more MCQ I presented to you, so please make a note of it. You might be asked question, the primary mechanism of bone formation in the condyle is what? You'll be given 4 options. So this is the best option you have to select out of the 4 options. Okay? And the part of the chin just above the chin protuberance, it undergoes bone resorption. You can feel little bit of concavity in this area. So all these figures shows how surface remodeling occurs. You can see, as I said, posterior surface of the mandible undergoes bone deposition. The anterior ramus undergoes bone deposition, and rest of the processes. Again, this shows a significant, this figure shows how the surface remodeling of the mandible takes place. Bone deposition, bone deposition, bone deposition, bone resorption, bone deposition. Then we have bone deposition at the coronoid process as well in an archaeal manner, and for the condyle also in a superior and posterior direction in order to keep contact with the cranial base at the temporomandibular joint. Okay. Now we have discussed how the growth of the nasomaxillary complex occurs. Again, to repeat myself, the cranial base grows in an upward and forward direction. The nasomaxillary complex undergoes growth in a downward and forward direction because of something called as secondary displacement. I hope you remember. Now, because the maxilla is growing in a forward and downward direction, and at all times, the mandibular teeth have to have contact with the maxillary teeth, right? Now, to maintain that contact, the mandible also has to grow in the same direction as that of the maxilla. So the growth of the entire nasomaxillary complex, the growth of the entire face, which is composed of 2 bones primarily, the maxilla and the mandible, the entire face undergoes downward and forward growth direction in accordance with the forward and upward growth direction of the cranial base. Is it clear? Now this figure also shows the same thing. Now, as I said, the anterior surface of the ramus undergoes significant bone deposition to make space for the developing first, second, and third molars. Now, you will get an MCQ here. I'll show that MCQ later on in this particular lecture itself. You can see the anterior part of the ramus has undergone significant bone resorption to make space for erupting second and third molars. Lingually, what is happening? If you observe the mandible from behind, lingually you will observe that the external part of the mandible around the around the coronal process undergoes bone resorption, and the lingual part of the mandible undergoes bone deposition, and vice versa for the inferior part of the mandible around the mandibular foramen area, mandibular process area, right? Now this is what I was talking about. I have an MCQ here for you. Just think about what I'm going to say and just listen to that carefully. I came across an MCQ. I think it was asked in PGI or AIMS INICET exam. I'm not very sure, but it was an interesting MCQ. That's why I put it here. MCQ goes like this. The question says, at the time when the child was around 6 years of age or 8 years of age, the operator, the observer, he put a metal pin, here around the posterior surface of the, sorry, not posterior, he had put the metal pin along the anterior surface of the ramus of the mandible. This pink dot is what is the metal pin. Now the question says, where will you find that pin? Where will you find that metal pin once the child crosses 18 years of age? Now think about it. It's an application based question. So I told you earlier that the anterior surface of the ramus of the mandible undergoes significant bone resorption to make space for the erupting second and third mandibular molars. Now apply that concept here for answering this question. It will be Niharika has said excellent. What about other people? Where do you think? Where will the pin be? Will it be in the bone? Will it be in the tooth? Or will it be in the soft tissues? I've given you 3 options. Will it be in the bone? Will it be in the tooth? Or will it be in the soft tissues? Tell me, come on, I'm waiting. So Niharika has said pin will be exposed. Okay, what about others? Come on, Harshita, Dr. Pooja, Aarti, Deep Priya, Ada, Gauri Sharma, Tanishka Gera, Apurva Patak. Come on, answer me. So Ulfat has said soft tissues. Very good. What about others? Raj Nacheka has said in the soft tissues. Excellent. Harshita has said soft tissues. Very good. So I think I made myself very clear here. So I'm very happy that you people are understanding the concept in a good way. I'm happy about it. Good. So correct answer will be the soft tissues. The pin will be exposed in the soft tissue. Why? Because the anterior surface of the mandible, the anterior surface of the ramus of the mandible has undergone significant bone resorption. So the part of the mandible which was sorry sorry, the part of the mandible which was at one point of time it was along the posterior surface has now become anterior surface, and the anterior surface which was earlier has now been converted into soft tissues. So you are correct, the pin will be exposed in the soft tissues, right? So this figure also shows the same thing, how the mandible is growing. We have bone deposition along the posterior surface, bone resorption along the anterior surface, and condyle which was here at one point of time, it undergoes posterior and superior bone deposition in this manner in order to maintain contact with the base of the skull at temporomandibular joint. Now again, correlate everything. Now again, by virtue of Newton's third law of motion, mandible is growing posteriorly, upward and backward. So how the chin will be? The chin will grow anteriorly, no? Downward and forward direction. It's again the same thing. Basic elementary physics. Newton's third law of motion. So again, the mandible has to maintain contact with the maxillary teeth. So maxilla is moving in a downward and forward direction. Similarly, mandible is also moving in a downward and forward direction to keep contact with the maxillary dentition. Okay? How the condyle grows? it actually grows in slight arc-like manner. I'll explain that arc concept, archial pattern of growth in the coming slides, just in a bit from now. So this concept was given by Ricketts. Actually, mandible does not grow in a straight line. Rather, the condyle does not grow in a straight line. It grows in an arc. How the mandible grows? I told you it undergoes subperiosteal surface apposition along the posterior superior surface of the condyle. And inside, what is happening? If you cut open the condyle, if you cut open section of the condyle, you'll observe that the condyle, which was earlier a cancellous bone, it consisted of red hematopoietic tissue, red bone marrow. We have red and yellow bone marrow, no? So red bone marrow, the primary function of red bone marrow is production of red blood cells. So this part of the condyle at one point of time consisted of red bone marrow. But with time, what is happening? With time, we observe deposition of bone along the endosteal surface of the condyle and resorption of the bone along the periosteal surface of the condyle. So what is happening? Because the inside of the condyle is getting deposited by the bone, so the bone marrow cavity, it is getting completely obliterated by ossified tissues, that is the bone. So the condyle, which was once upon a time a blood forming bone consisting of red bone marrow, it is now converted into a solid structure of bone composed of ossified bone, which does not have any bone marrow. Okay. Bone resorption occurs at the anterior region. Where, beta? In the mandible, bone resorption is occurring only here, only at just above the chin area. You can feel for yourself. You can feel it yourself only. Just put a finger here and see a small depression just above the chin. But rest of the mandible is undergoing bone formation. No, the chin is undergoing bone formation. At the same time, to maintain contact with the base of the skull, the entire mandible is moving forward. Now, Shiv Nashirin has asked me, is the anterior surface of the ramus become posterior surface of body, sir? Anterior surface of ramus become posterior surface of body. But there is nothing called posterior surface of body. Posterior part of body of the mandible. Yeah, yes. It becomes the soft tissue, not the posterior part of the body. The anterior surface of the ramus becomes soft tissue. That's why I asked you that question, no? Where will that pin be? It will be present in the soft tissues. Okay? Now what happens at the ramus corpus junction? There's something called antegonial notch. Now antegonial notch, you can observe it yourself. Just put your finger here, just in front of the angle of the mandible. Try it yourself. You will observe a small depression of the bone. That is antegonial notch. So antegonial notch, you can say the ramus of the mandible and the body of the mandible, they form a small angle because of the anatomy of the mandible. So the small depression here present where the posterior surface of the ramus and the mandibular plane, they join together just in front of the angle of the mandible. That depression is known as antegonial notch because that part undergoes selective bone resorption. Okay. Now one thing to remember, the antegonial notch is always more prominent in vertically growing patients and not very prominent in horizontally growing patients. Just have to remember that because this can be a clinical topic to consider. We'll be transitioning from basic topics to clinical topics in due course of time, maybe 3 or 4 classes, 3 or 4 days from now. Now this figure shows how the coronoid process grows. It also undergoes growth by means of Enlow's V principle. Again, I'm telling you. So please pay attention. We'll be discussing about the Enlo's-V principle and other theories of growth in the next lecture from now. So we have bone deposition along the inner surface of the coronoid process and bone resorption along the outer surface of the coronoid process. So the overall direction of growth is in upward and backward direction for the coronoid process. Okay. Ramus uprighting. Next topic. Now what happens at the time of birth? At the time of birth of the child, at the time of growth of the child, what happens? This angle between the ramus and the body of the mandible is approximately 160 degrees. Actually, some books say it is 180 degrees, but I don't believe in 180 degrees. 180 degree means straight line. How can it be straight line? Just think about it. How can the junction between the ramus and the body of the mandible be a straight line? That's why some other books say it is around actually is a range 145 degrees to 160 degrees. That's a correct range for the mandibular angle present in a child, in a newborn child. Correct. Now as the person increases in age, as the maturation of oral structures occur, now as I said earlier, the posterior surface of the mandible or the posterior surface of the ramus of the mandible undergoes significant bone deposition. Now we have selective more bone deposition along the inferior surface of the posterior surface of the ramus of the mandible, and as you go up, the bone deposition decreases. So that's how. And similarly, along the anterior surface, there's more bone resorption along the inferior surface of the anterior surface, and as you go up, the extent of bone resorption decreases. So the entire ramus and the body of the mandible, the angle between the ramus and the body of the mandible, it reduces from 145 to 160 degrees in a newborn to around 120 degrees in an adult. So that is how the angle between the ramus and the body of the mandible decreases as the age increases. Okay, so we have this MCQ also. I know you will ask me questions, sir, this book has given 180 degrees, that book has given 180 degrees, that MCQ, that Pulse has given 180 degrees. But just think about it, bache. These books are not standard textbooks. Standard textbooks are Prophet, Gurkirat Singh, Balaji, Bishara, Graeber Vanasal, and so many other books. So many international bestsellers. O.P. Kharbanda. Pulse is not a standard textbook. Pulse might have given some justification, but you think about it logically. 180 degrees is just a straight line. How can it be 180 degrees? So this is the angle between the ramus of the mandible and the body of the mandible, that is around 145 to 160 degrees in case of a newborn, which reduces to 120 degrees because of a process known as ramus uprighting. Right? Now next topic. Growth of the condyle repeat. Now the growth of the condyle, I told you, it undergoes subperiosteal surface apposition. The growth occurs in a posterior and superior direction to keep the mandible in contact with the temporomandibular joint at the glenoid fossa. Okay. Now we have something called as ramus uprighting. I told you we have more deposition here, less deposition as we go up, and more resorption here and less resorption as we go up. So the entire angle between the ramus and the base of the mandible changes from 145 degrees to 120 degrees. Niharika has asked me when we'll be having break. Just 10 more minutes, bache. You can have breakfast after. You should have done breakfast before, no? You should have fresh mind before coming for the lecture. Okay, just give me 10 to 15 minutes more. So mandibular foramen. So mandibular foramen is protected by a mandibular process. So we have bone deposition along the anterior surface and bone resorption along the posterior surface. Not a very important topic. Mandibular notch or incisura mandibularis. This is the mandibular notch. So as the conoid process undergoes bone deposition, it undergoes Enlow's V principle of growth. So we have bone formation here and bone resorption here. So that is all about mandibular notch or incisura mandibularis. Then along the buccal and the lingual surface, we have surface remodeling. The same surface remodeling what we talked about in the maxilla, same surface remodeling we are talking about in the mandible as well. So we have bone deposition here and bone resorption here. Bone resorption along the lingual surface and bone deposition here along the lingual surface. So these areas correspond to where the muscles of mastication attach to the body of the mandible and the angle of the mandible, especially the medial pterygoid muscle along the lingual surface of the mandible, and the masseter muscle along the ramus along the buccal surface of the mandible. Now growth in width. What is happening? The mandible itself is growing in the width as well. So there are 3-4 mechanisms behind it. One is increase in the intercanine width. One is surface remodeling, plus the growth of the tongue, the growth of the floor of the mouth. So all these phenomena, all these growth of the different structures contribute to the growth of the mandible in the width. Again, growth in length. This is again a V principle of growth. Again, I'll explain the same thing in the next lecture. So what happens here? Once you look at the mandible from the top, it's like a long bone converted into a horseshoe shaped bone just by bending it in the center, right? That is growth in. That is how the mandible is once we look at it from the top. Now it undergoes V principle of growth, where we have bone deposition along the inner surface and bone resorption along the outer surface of the growing ends of the bone. So the overall direction of growth of the mandible is anteroposterior, at the same time laterally also. So the mandible grows in a V-shaped direction. So this principle was given by Enlow, which I'll be discussing more about in the next chapter. Growth in height. I told you, once the teeth erupt, that's how the growth in height occurs, because the alveolar process also develops along with the teeth. So we have bone deposition here, bone deposition along the inferior surface of the mandible. So the entire height of the mandible increases. We have talked about ramus uprighting. We have talked about growth of the condyle as well. Okay. Now this is an interesting concept. There are two perspectives of looking at the growth of the mandible in a downward and anterior direction. The first concept, when viewed from the perspective of a stable cranial base. Now what happens? Now this is the stable cranial base. This is the point of reference for us. The mandible attaches to the cranial base at the temporomandibular joint. Everybody knows that. So keeping the TMJ as a reference point, we observe that the chin grows in an anteriorly and downward direction. I told you to keep the mandible in contact with that of the maxilla and to maintain the growth vector along with the nasomaxillary complex. So that's why the growth of the mandible occurs in a downward and forward direction when viewed from the point of reference from the cranial base at the temporomandibular joint. That is one way of defining the growth of the mandible in an anteriorly and downward direction. Second point of reference is here at the chin. Right? when viewed from the point of reference of vital staining in the chin area. Now, if you look at it, you keep the chin as a reference point, you will observe that the condyle and the coronoid process both have grown in an upward and posterior and superior direction, right? So there are two perspectives of looking at the growth of the mandible. Both are correct in their way. Both are absolutely correct in their way. But we will be discussing more about first point of reference. So that is universally accepted that the growth of the mandible is always downwards and forwards in accordance with the growth of the maxilla. But the growth of the condyle is always posterior superiorly by virtue of oppositional or one second subperiosteal surface deposition. So please make a note of it. You have an MCQ here. The growth of the condyle can be explained by which mechanism? So you have the answer, subperiosteal surface deposition. Right? So this is again the same thing. We have talked about this many times earlier. The arrows show the direction of changes of the growth of the bone. This we have talked about earlier. Now, protected nerve concept. This is what I was talking about when I was talking about the growth of the condyle and of the coronoid process. So there is a logarithmic spiral growth or the archal growth of mandible which was put forth by Ricketts. Now Ricketts is like a, he's like a, what do I say? He is like a god of orthodontics, and he has an extensive research in different fields. So we have in post graduation exams, theory exams, we have 100 marks question about the contribution of Ricketts in the field of orthodontics. So just imagine single question asking about a single author containing 100 marks, and we have to write all the different contribution what this person, Dr. Robert Murray Ricketts, has given to the field of orthodontics. So just imagine how much dedicated he was towards this profession. Anyways, so protected nerve concept means what? In nature, everything is symmetrical. So what happens? I think everybody must have seen a snail, that ghonga snail, mollusk. It's I think it's a mollusk. I've read Animal Kingdom during my NEET UG exam, so I remember it's a mollusk. So the shell of the snail, it follows a logarithmic spiral, no? Like this. Yes or no? Okay. So similarly, that logarithmic spiral is what is followed by the growth of the mandible, that is explained by the archal growth of the mandible. So what this concept says, that the mandible doesn't always grow in a straight line manner. The growth of the mandible is always in an arc like manner, like this. You can see how the mandible is growing. The mandible is growing in an arc like manner, and if you extrapolate this arc, you will obtain this kind of an logarithmic spiral for the growth of the mandible. Excuse me. So this is a complicated topic. I'll leave it for discussion for some other day. Maybe when any of you will pursue their post graduation in orthodontics, maybe that time we can discuss further about the protected nerve concept and the archal growth pattern of the mandible. It's actually quite difficult. It's like a it's like a headache to understand everything in entirety. So for the time being, just remember that the mandible always grows in an archal-like growth given by Ricketts. So that's all for the first lecture. We'll just have a break of 10 minutes as Niharika can have her breakfast also. So come back in 10 minutes. We'll have a break in 10 minutes and then we'll start with the next topic, that is general principles of growth and development. Stay tuned.